Another thing to consider with cognitive processing therapy is that if we don't get at the deeper stuck points and the deepest shame, we're not going to resolve PTSD. It's still going to live in there, right? And so we don't want to disservice our patients by not going to the worst of the worst. Then what is the point of therapy if we're just kind of taking off some layers but not getting to the roots? And the root of PTSD, especially as it pertains to childhood sexual abuse, is guilt, shame, regret, and responsibility. If you're treating somebody in this domain, then it is absolutely your responsibility as a clinician to educate, give examples that normalize, and then ask directly about the toughest stuff. When I am talking to patients about the details of their trauma, I will ask directly about what happened, where it was touched, how it happened. I will give a multiple choice list of things that can happen to somebody, what perpetrators do, and ask them to verbalize A, B, C, D, E, or F. If we think about how the brain works, and this is why I keep my brain model here all the time, because what it takes to speak and report something is frontal lobe, right? The brain goes in like this. This is the frontal lobe, executive function. This is the ability to control attention, emotion, and behaviors. This is the ability to reach back into our memory banks and our word processing centers and pull forth language. When we have a model of PTSD, then what's happening is brainstem and limbic system, especially the amygdala in here, is flared up. When this area is flared up, the frontal lobe literally goes offline. This is an inverse relationship. So when limbic system is high, frontal lobe is low. When frontal lobe is really online, then our limbic system is calm. But if I ask a trauma survivor to tell me what happened to them open-ended, if I just say, well, what happened to you? What did she do to you? Most times they're going to clam up because they're going to go straight into limbic system arousal and frontal lobe is going to go offline. If I give them an option list, though, of areas of their body that it happened in, words that explain what happened, and ask them to say yes or no or pick one of three, it's much easier of a process for them to do. Even if their limbic system is flared up, they don't have to do all that work of the frontal lobe. So that really helps a patient report something that happened. So this is important to remember with PTSD. When I educate a patient on PTSD, I talk about the brain and what's happening in the brain. And when we look at the two sides of the nervous system, our autonomic nervous system breaks down into the sympathetic nervous system and the parasympathetic nervous system. Sympathetic nervous system is our stress response. This is our limbic system flaring up at a perceived threat or stressor. The parasympathetic nervous system is our calm and relaxed response. Heart rate goes down, frontal lobe comes online, limbic system calms down. Another thing that we want to help them understand is a lot of the PTSD symptoms are coming from the limbic system in the brain, specifically the sympathetic nervous system arousal that really lights this up and takes the frontal lobe offline. We want the patients to understand this so they can understand that their symptoms really come from how their brain is functioning. With good evidence-based therapy works because we're training the nervous system and the frontal lobe to come back online and get the limbic system calmer and bring on board the parasympathetic nervous system. In the beginning modules of cognitive processing therapy, this is broken down even more, and it lays out how to work with a patient with PTSD and educate them about the PTSD process. As a clinician, when you are working with childhood sexual abuse or sexual assault, it is very important to ask directly about what happened. And we can do so in a way that matches the patient's comfort level, but you have to remember that the patient is wildly uncomfortable no matter what. And they live with these memories in isolation with lots of shame regarding how somebody else is going to perceive them. So one of our biggest roles as a clinician is to do a really good assessment where we're asking direct questions and making it more normal for them to talk about it. I think something to consider, especially when we're feeling nervous as a clinician asking about a patient's trauma, is that number one, what gets rid of shame is to normalize somebody's experience. So if we can tell a patient is really hesitant in speaking up, we can talk about other patients that we've had and their types of trauma and how we've worked with them and how it's very much of a collaboration in terms of the patient with their experience working together with a therapist. We can also remind them that we've heard pretty much absolutely everything and that our job is to create a container for that. So there's no detail that they can tell us that we're not already going to expect or that we don't know exists in the world of childhood sexual abuse and sexual assault. I tell my patients that I will ask them directly about what happened. And it's okay to put that in this space because that's what this space is for. And it's an experience that happened to them. So it doesn't have much to do with them. And that our job is to decrease shame by shining the light on exactly what happened, pulling it off the shelf, shifting through it, and then making sure we put it back up there in a more organized way that they're going to feel way better about. So I encourage them to tell me the details. And then I ask specifically. I ask questions like, was it rape or was it just touching? And if it was touching, was there any insertion of fingers in any part of the body? I list the body parts out and ask directly. If a patient I can tell is really symptomatic and even having a panic attack, I'm not going to ask those questions because I'm not trying to push the symptoms over the top and for them not to come back. So I'm constantly doing an assessment around what's going to be most helpful for the patient, but I do a lot of normalizing around what happens in sexual abuse and why it's so hard to talk about.